chronic GvHD is the most common long-term complication after otherwise a successful allogeneic transplant that occurs up to 50% of the recipients. It's associated when it's severe with the impaired quality of life. But it is also something good about chronic GvHD is that it's also associated with a decrease in recurrent malignancy, independent if the chronic GvHD is mild, moderate, or severe. While the severe forms decrease mortality, the mild can still elicit the graft-versus leukemic effect, which we rely so much for eradicating the malignancy. And the chronic GvHD is caused by inflammation and fibrosis and can affect multiple organs, here being the most common one, and it's more or less common in other organs, and it's very controversial in some other manifestation. What is the risk factors for chronic GvHD is using a mismatch or unrelated compared to a matched sibling, peripheral blood instead of a bone marrow if we use a conventional GvHD prophylaxis, having a female donor specifically if it has been pregnant before to a male recipient. Older age is more susceptible to develop this complication. For acute GvHD, and the steroid use is still at the 100 days post-transplant. What is associated with decrease is using the STIN depletion modulation that actually has been, some of the pioneers of this has been at the Hutch. And you heard from Dr. Freddy Appenbaum early on about the manipulation of the peripheral blood T cells to just give the ones to prevent infection and to elicit the graft-versus leukemic effect without with a very small complication from GvHD. This is also accomplished by new therapies that we have used in combination with other immunosuppressants to prevent GvHD, such as post-transplant site, and autograft sources associated with less chronic GvHD, such as umbilical cord. So here is the most common sites. It's involved the skin, mouth, eyes, liver, and GI. Most of the people have 3 organs involvement, and many requires 3 to 5 years, and a small proportion requires for many, several decades. The successful immunosuppression treatment in patients with chronic GvHD, this is a study from the Chronic GvHD Consortium that Stephanie Lee leads here in our center, shows you that just a minority of patients, the majority of them received second line, third line, even fifth line therapy to control this complication. And the prevalence, if we look at 5 years, the prevalence of patients who develop chronic GvHD and require treatment and receive, and we looked at them at 5 years, about 30% only will be off immunosuppression and disease-free at that time. So that's still a problem that we see here. And what is the manifestation that really we wanted to prevent so that they don't get to this extensive or severe manifestation, including the scars under the skin that we call sclerosis that can affect the joint movement. It can affect the mouth, and when very severe, it's difficult to eat and cause weight loss and a lot of teeth decay. It can affect the eyes and can affect the lungs, although this complication is less frequent than the mouth and the skin and the eyes. So if we look at the sclerodermoid or fasciitis type of chronic GvHD, the cumulative incidence is about 20% for patients who develop chronic GvHD. And the incidence of lung GvHD is about 5 to 8% of all allogeneic transplant. But if we look at the patient who develop chronic GvHD, it's about 10 to 14%. The diagnostic criteria is done with pulmonary function test, and it does the importance of, even if somebody has no symptoms and they had received an allogeneic transplant, we do periodically pulmonary function test to detect this complication, which usually happens in the first 2 years post-transplant. The goal of the treatment for both sclerotic and lung GvHD has to the management follows 3 principles. Goal of treatment. So what is the goal of that treatment? Is it to alleviate the symptoms? Yes. It is to use a treatment that it's less toxic? Yes. Is it to prevent the progression from the problem? Yes. So all those things are 3 elements of the goal of the treatment. Use the most effective treatment, the least toxic one, control the symptoms, and prevent progression. There has been new therapies, and it's a very exciting time in the last decade or so, that we have developed so many more new approaches to prevent the chronic, but also to treat chronic with less toxic regimens. And of course, the supportive care, which can be important not only to control the symptoms, but to prevent infection and to prevent disability. So there has been a significant advance in chronic GvHD pathobiology, and you're going to be hearing this from Dr. Jeffrey Hills, but also from Dr. Stephanie Lee, who has led our chronic GvHD consortium at the Hutch. So I'm not going to talk to you about the advance in chronic GvHD, but I will tell you that there is an inflammatory tissue injury. So this attack to the body from the donor immune system can cause acute inflammation, tissue injury, and then can lead to chronic inflammation and dysregulation, and then the aberrant tissue repair. So the way that the tissue repair can be aberrant, and it can lead to fibrosis, and that's when we lose function, and those functions can be permanently. So there is a list of approved therapy that has been developed, and those are listed here for chronic GvHD treatment. It's the ibrutinib, the ruxolitinib, and the belumosudil. All these drugs were not available when I joined the Hutch in their long-term in 1990. We only had prednisone, cyclosporin, and then we have other clinical trials with thalidomide, with MMF, with sirolimus, all early on to try to see if we could prevent the progression. And those efforts were not very successful. But to treat secondary refractory GvHD, there has been a lot of progress. So the management of chronic GvHD severity morbidity, such as skin sclerosis and fasciitis, we have many, many therapies now that we are testing for this particular manifestation, and the lung GvHD as well. So in the sclerotic manifestation, we are definitely placing patients on clinical trials because we're still not convinced that we have the best treatment for this complication. And there is 2 drugs that has been now being used, tested here. We use ruxolitinib, which is the approved drug, also called Jakafi, the belumosudil, that it's also called Rezurox, but we also use other therapies that has not been approved with some evidence of efficacy listed here. And we say refer early to physical therapy for strengthening the exercise. And in the lungs, we use the fluticasone, which is a corticosteroid inhaler, another beta agonist to improve the opening of the bronchi, an antibiotic, which has activity against inflammation. And we do now have a chronic clinical trial with ruxolitinib for this specific complication. Aggressive treatment of pulmonary infection and pulmonary rehabilitation. Remember that 50% at a medium of the patients who discontinue immunosuppression, 50% at a medium of 3-6 months after stopping will require treatment. So I talked to you about the lines of therapy. I reviewed this, and then I would like to pass it on to Kristin Geary to talk to us about the eyes and mouth manifestation of chronic GvHD, and after that we can open for our interactive workshop. Thank you, Kristin.
Okay, So I'm Kristin Geary, one of the nurse practitioners in the long-term follow-up clinic, and I'm really happy to be here this morning to talk to you a little bit about chronic GvHD and specifically how it impacts the oral and ocular areas and what we can do for supportive care. And just as a reminder, this presentation is being recorded and there's the long-term follow-up email if you have any questions that you think of after the workshop today. So oral chronic GvHD is one of the most common manifestations we will see. And so when I am assessing a patient in clinic, I'm looking for two components. So first, what are the symptoms that someone is experiencing? And so the first sign we'll often see is the development of new sensitivities. So for instance, a month ago, if you weren't having any problems with certain foods, but now things like spice, carbonation, or mint are bothering you, that could be a sign that there's new inflammation in the mouth. Now, oral dryness can also be a component of chronic GvHD, but this can be a bit harder to tease out because other things can be contributing to that, so such as prior radiation, current medications, or certain habits. But if the dryness is accompanied by the sensitivities or also with the pain or soreness, then we're thinking, okay, that could be also a component of the graft-versus-host disease. And so with the physical exam, I'm looking for three features. So first is the very distinct finding, which is the lichenoid changes. And I'll show some examples of this. There can also be erythema or redness affecting the tissues. And then as the inflammation progresses, there can be ulceration. And so a bit about the mucosal symptoms. So when there's inflammation, it can lead to thinning of the mucosa, which then develops the sensitivities. And so we know there's common triggers that patients will report to us. So things like carbonated beverages, acidic flavors, strong flavors such as minty toothpaste, rough textures such as chips or spicy foods can all worsen those sensitivities and the inflammation. And so here's some examples of what I will see on physical exam. And so you can see the different types of the lichenoid changes we see. So they can be these sort of fine, lacier changes, or more what we call hyperkeratotic changes, which I think of as a more thickened, kind of piled on appearance there. And so a bit about the lichenoid changes. So if they're responding to treatment, such as with topical steroids, we're less concerned that it could be a oral cancer, but we do know that the subsequent malignancies are increased. There's an increased risk after transplant. And also when you have the inflammation in the mouth from chronic GvHD, this can also predispose to those subsequent cancers. So it's just important to be aware of that. If the lesion is persistent or increasing, that it needs to be evaluated by a dentist, just to really be on top of any potential oral cancers. And then the other thing I look for is the redness in the mucosa or the erythema. And just a note about that is if you're trying to examine the mouth, if you use kind of what I think of an old-fashioned kind of halogen source flashlight, or I guess incandescent bulb, it gives that warmer tone and we can really see the red tissue more easily. Whereas if you use an LED light source or such as from your smartphone, we can really pull out those more lichenoid changes. And then lastly, we'll see the tissues can become ulcerated, and that's often when we get more reports of pain. And so once the symptoms have progressed to having some oral pain, we look to see if we can treat these topically. So our most common approach is to use a steroid rinse, such as dexamethasone. There is also a more potent topical steroid called clobetasol, and often this is used more of a spot treatment as a gel on an ulcer or a specific lichenoid or hyperkeratotic lesion. But our oral medicine service has more recently even been compounding the clobetasol to be a more potent oral rinse. The tacrolimus ointment can be used in areas like the lips, where we want to avoid steroids so we don't have side effects such as thinning of that mucosa. And then I'm always also looking for, are there other things contributing to symptoms, such as an infection with yeast or reactivation of herpes virus. So if there is a yeast infection, we can treat topically with the nystatin or clotrimazole. And then for patients that remain on systemic immune suppression, we continue the herpes virus prophylaxis with the acyclovir or valacyclovir. And I wanted to mention a bit about dry mouth because it can be so, have such an impact on patients' quality of life. So this was suggestions of things you can do. So take something as simple as frequent sips of water. There are things to stimulate saliva, such as using sugar-free mints or gums. There's over-the-counter oral moisturizing agents, which can be like a liquid or a spray. When I was preparing for this, I learned that there's over 500 medications that can contribute to dry mouth. And so looking at your medication list to see, is there something in particular that could be contributing that we could minimize or change, that might be helpful. There are also some prescription medications to help increase saliva, but this needs to be considered closely, for side effects, and does the benefit outweigh any risks. A very, maybe easy thing to consider is how much coffee are you drinking? Is there a way to decrease caffeine? Because that can also contribute to dry mouth. And then dry mouth in general will predispose for more dental caries. So it's really important to have good oral hygiene, brush, floss, see the dentist regularly. They may prescribe fluoride treatments, and then just avoiding the mint toothpaste, which could also be more drying. And so now shifting gears to talk about the ocular manifestations of chronic GvHD. So we look for new onset of a dry or gritty sensation. So we ask, does it feel like you have sand or grit in your eye or some other foreign body sensation? And sometimes patients will first report that they have excessive tearing. And so I think of this, that it can be an early sign of the chronic graft-versus disease in the eye affecting the tear quality. Or you may need to start using eye drops regularly when you did not before. And then the inflammation can progress to where you have sensitivity, burning, pain, and it may impact and cause blurry vision. So then on physical exam, we look for redness or injection of the whites of the eyes, inflammation of the eyelids, so puffiness and redness, that's called blepharitis. There can be sort of abnormal mucus production, and you may wake in the morning and have crusting in the eyes. And then you can also become very photosensitive to light, such that I see patients that will need to keep the lights low in the exam room or be wearing sunglasses during their visit. And so again, the ocular GvHD can be quite common, impacting greater than 50% of our patients. And thinking about biologically what's happening, so the inflammation can affect the lacrimal glands, which are on the tops of the eyes, and they make the aqueous part of the tear. It can impact the meibomian glands, which line the eyelids, and those produce more of the oil component of the tear. And then there can just be that general inflammation on the cornea or the conjunctiva. And so this is an example in photo A of how an ophthalmologist can look at the surface of the eye with a special stain, and where that green uptake is shows where there's actually some erosions and irritation on the cornea. And then in photo B, it just shows how injected the whites of the eyes and the conjunctiva can be when there's the active inflammation. And so what can we do about this? What are some strategies to help with this treatment? So one thing is to try to increase the ocular surface moisture. And we can do this with preservative-free artificial tears or viscous eye drops. So they can not only be soothing, but it can also help to calm down the inflammation. And then the omega-3 fatty acids, there's been conflicting reports with how helpful that may be, but we think it's something that can easily be tried, taken orally, and has probably low risk of side effects. The autologous serum tears, are something that can be generated from a patient's own blood. And again, these can be soothing, but also have some anti-inflammatory effects. And then another strategy is to control evaporation in general. So you have these drainage ducts called puncta in the eyes. And so these can be occluded either with plugs or cauterization and prevent the tears from draining to maintain some of that moisture. Same with moisture chamber goggles. So these can be worn, especially if you're going to be outside or in a windy environment, and they may help keep the eyes from drying out. Scleral lenses, you can work with an optometrist to get these prescribed and fit, and they can be really improve patients' quality of life when they need to use lots of eye drops. They can just help protect the surface and prevent further damage, and just make the day-to-day, dealing with the ocular GvHD much better. So then in terms of the eyelid inflammation or blepharitis, using warm compresses, doing good lid care to prevent styes or other infection, and then use of topical anti-inflammatories can also be helpful. And those anti-inflammatories can also help decrease the inflammation on the ocular surface. And so cyclosporin eye drops, those can be used if they're helpful for the long term. Topical corticosteroids such as prednisone type eye drops, those are more for short-term use and should be given under the direction of an ophthalmologist just to monitor for side effects. And then a newer agent, this topical lifitegrast, it's FDA approved for treatment of dry eye, but hasn't as of yet been studied for chronic GvHD. And so just some take-home messages. So just to remember that the oral and ocular GvHD are common. They can be managed with supportive care. Avoiding the triggers and irritants that I discussed can be helpful while optimizing those topical therapies. And I think aside from working with your primary provider, having a dentist or ophthalmologist who's familiar with chronic GvHD can be helpful, and especially essential in monitoring any other post-transplant side effects. And so I'd like to thank you for your attention. I know that was a lot of ground to try to cover in the short time, but I look forward to taking any questions during our workshop, and I will stop sharing and turn it back over to Dr. Flowers.